So I would be trying.
Well, I knew when they said.
Not you.
I thought I did an email.
They moved me out of it. It takes me
Yeah, the whole record, right?
Good time was that?
Yes.
I missed
The first one that I know of.
Where are you? With the Pope?
The old Pope.
Where were you?
Yeah, we have that look.
Well, we had a good time. The weather got better progressively.
Good, yes. No question. Thank you so much.
So do you have any pictures to show me?
No, that's just the sign of getting old and forgetting.
No, isn't it? All of this has got
It's
stuff
true,
in
but a
it.
lot of people
I'm not sure what.
No?
More raisin bagels. More, there's none. There's no raisin bagels. There was one and it's gone. You were late.
So that was a whole lap. So that's the next request. I have to go up with raisin.
More raisin bagels.
Didn't go to
Familiar, I believe we must have met. Have you been at Western Society? Or, okay. Yeah, I know we've seen each other. So, good, yeah. We've probably been in the same circle.
She's coming to the whole West Coast.
All worked out.
Right now, we're living together. Just live in Sheffield.
You know, Fridays. So where you need my existence.
Thursday.
Oh, it's awesome. Friday.
I
helped set up.
They did. So we're trying to Sacramento and going back towards geography for the next few months.
See what happens.
Decide maybe. Yeah. Maybe my husband will
My regular experience
Can't get to your
Sonoma.
Sounds good. That just, you want to be slide to say I'll point out everything you're talking about, or I'll try to. I'll be like your Vanna White.
Got it? Santa Clara.
Oh, it's great.
And the accelerator is 30-minute line. This is at 9 o'clock. I got it. Well, and the Glacier Express has like a 20. I'm not going to get up in the cheap one.
Congratulations.
It is oh, sure. I got a test. So we get off the rope tow. They said,
Tesla?
so let's
Oh, that's what you were plugging in that as it blown up. It has a turn. It's not on fire. You love it?
no idea what it is. So my daughter goes, Dad, what do you think? That was about $600.
Friends just saw it.
You don't get that.
They're
very good. Helicopter.
We'll be in touch.
So it was awesome. But we only got one run. It was like lemming.
I'll be there. Oh, wow.
Might save money on the way out. We gotta go to the airport.
Damn bowls. You know, people are ordered about. You can keep just working more traffic.
The first part is what you said doesn't happen. They're nice about it.
I know.
Take one of each of these. Holy cow. They want to get 8 people and then lose up 30 feet of snow. And you come back and do it again.
What? No, I missed some parts.
Yeah, I did, but I'll
So what's the name? Bioaerosol instead of
Senior graduate.
I know.
Looking California.
Yeah.
I was amazed.
No, look at,
Out of all of these. That good.
The young boy. He did reversible. And graduates out of neuro and he had a few personal. We had a lot of obstruction. Sorry? Yeah.
How's the weather up there this time of year?
See that CF.
Beautiful. Right now it's been 28:30 and sunny, clear.
All right.
But we did have some snow yesterday, and mostly snow throughout the week.
Yeah. All right, let's get started. The word of the day is bioaerosols. You have to capitalize the A to get credit. You don't. This is going to be a little more difficult. We have some outside speakers. Jeff Demain was nice enough to call in from Alaska, and it's an hour earlier there, so he's a trooper to do our first two talks. It's not as easy as it used to be on the old Citrix WebEx-based system, so we're going to have a speakerphone, and I'm going to advance the slides for Jeff and possibly Art Bay. So I will let Len get started here.
So we've got the job of reviewing a 5-day meeting in 1 hour, which is near impossible, but we'll just hit the highlights. And 5 people actually sent in PowerPoints. I just made this one slide, just a very quick overview to get us started. So there were 4 plenary sessions, Saturday, Sunday, Monday, Tuesday, and the main theme of those were as listed there. The first one was on immunotherapy, a lot to do with mechanisms and bioassays that may be in our future to sort of determine efficacy and perhaps determine when people can stop. A topic called integrated airways, basically sinusitis, asthma, drug allergy, which I thought was the best. And there was one particular talk that day that was amazingly elegant work, talking about how HLA and drug allergy lead to unique problems in people just with HIV patients with a specific drug, lead to severe drug allergy in people with very unique HLA haplotypes. And then the last day was bioaerosols. I thought that if there were major themes, there are a lot of topics, there are a lot of sessions on particular topics. The ones that were impressive to me were continuing to discover new immunodeficiency diseases almost daily. Maybe 1 or 2 people in the world with those diseases, but yet they get described. New big push continues on food allergy. And the other thing that I thought was a big coming future for us is more use of molecular diagnostics, specific proteins, and especially for food allergy diagnosis. So 5 people sent in PowerPoints that we've got. First is going to be Jeff, who's got 2 papers that he wants, or 2 sessions he wants to review. He's going to be on the speakerphone from Anchorage, and Drew has very nicely worked out the technology, so hopefully it's going to work.
All right, Jeff, whenever you're ready, have the first slide up.
Okay, thanks. Good morning, everyone, and welcome back to Seattle. And it's nice to be able to communicate with you, telecom. I have no disclosure at all. So this is what I learned the way I can, and this will be dupilumab. Dupilumab is a monoclonal antibody that is novel. It's fully humanized, and this is a very elegant study that was done by Dr. Bieber, lead author. He was unable to be at the meeting, so his second author, Dr. Demain, presented the paper. So dupilumab targets the IL-4RA subunit, or CD124, and this very specifically blocks the signaling for both interleukin-4 and interleukin-13, and therefore blocking the driving of the Th2 pathway. Through 2 receptors, this occurs. There's a type 1 IL-4R and a type 2 IL-4R. And they really go down 2 of the primary pathways. One is primarily through the JAK kinase pathway, then it'll end up ultimately at STAT6. But the key is it's really just not driving Th2, and preferentially will drive Th1. Dupilumab is given subcutaneously at 300 milligrams once a week, and like I said, it's fully humanized. In the study model, there's a 12-week randomized double-blind placebo-controlled study. There was 109 patients enrolled. There's no topical agents used. This is for severe moderate to very topical dermatitis. There was no topical agents used during this period of time and during the just prior to the study. The endpoints were basically subjective scores. One is called the Eczema Area Severity Index, 50%. In other words, what percentage of patients had a 50% improvement? And then the other is using a more specific scoring called the SCORAD, which I think we're all familiar with. For inclusion, it was adults greater than 18 years old, moderate to severe atopic dermatitis for at least 3 years. That was poorly responsive to topical therapy, and they had at least a 10% surface area involvement. So, for the results, again, but these are subjective scoring. The number of patients that reached 50% improvement, dupilumab had 85%, and then placebo, which is always surprising to me, had a 35% improvement, which makes you wonder if maybe there was some contact dermatitis going on with topical steroids or other agents used. The percent, and this is looking at percent change or percent improvement. Dupilumab was a 74% improvement, whereas placebo had a 23% improvement. Adverse reactions were primarily site reactions, like we would see with other monoclonals. None of them were severe, but they're about the same between dupilumab and placebo. Interestingly, skin infection was, not surprisingly, was much lower in dupilumab than the placebo group, with placebo having 14 or 26% of patients affected, or 4% or 2% of the dupilumab patients. I'll be honest, they listed a few other side effects or adverse events. The next one that I can remember was nasopharyngitis, but none of those were really very significant, and I honestly couldn't, my notes, I couldn't take them quick enough, and all I had was a very simple abstract to reference. So in conclusion, this is a novel mechanism of action. It's rapid, with marked improvement, as demonstrated by the subjective scoring. They felt that optimal benefit was achieved in 60 days. There was a significant reduction in atopic dermatitis symptoms, then had the potential impact on quality of life measures, although that was not one of the endpoints. No serious adverse events, fewer skin infections, and generally well tolerated. As an end note, this dupilumab is being studied in asthma, although to my knowledge it was not presented anywhere at the meeting, but I think we have more to come on that. So, can I answer any questions about dupilumab? You really kind of know everything I know is on the slides, but
I think there is already published or presented data with success in asthma. Actually, I saw the asthma data before I saw you give this paper, so it's also been successful there.
Okay. And I did see the paper, but I did see the point that I think it was last year it might have been presented, but I have personally not read the paper.
Is there any rebound when you stop therapy? You said maximum effect is 60 days. Then do they continue or do they stop?
At 60 days, there was, I think I heard the question right, at 60 days, there was continued improvement, but really at 60 days, that's where it peaked, and it really plateaued at that point. In fact, I believe, again, I'm trying to go back and remember this, it almost seemed like with dupilumab, it might have been just a few percentage points where it even trended down a little bit. But that was really where it kind of peaked out.
All right, Jeff, you ready for the next one here?
I am.
All right, we're ready to
Which
go.
product is that?
I think it's Sanofi event. There were several companies involved. It's being done in Germany. It was a German company I didn't recognize, but Sanofi, a couple of the authors had Sanofi disclosures, and they were listed as Sanofi employees. There was about 12 authors on that paper.
I'm looking at my notes here, and in the second day's plenary session, Sally Wenzel, she's the one who's already either published or certainly presented it, so In her plenary talk, she talks about its efficacy in asthma, and by all the markers that you would want to look at clinically, people got better, their exhaled nitric oxide went down, their eotaxin levels went down, and so forth.
So I think it's a very exciting drug, a very exciting product for us, hopefully available in the near future. Probably within a few years. Okay.
The next one's ready to go.
I'm ready?
Yep.
Okay, so what I also learned the way it can, and we're going to talk about how systems split. And so that was sublingual immunotherapy or oral immunotherapy was certainly a prominent focal point throughout the meeting. This was a late-breaking abstract. The title was Dose Finding, Efficacy, and Safety Trial of How Such Might Sublingual Immunotherapy using an environmental exposure chamber. This is a Merck product. Dr. Ken McNulty presented it. This was just really a beautifully designed study, very, very well done study. And that was one of the reasons that I selected this. So this is sublingual dust mite. They're using the oral dissolvable tablet, and they studied this at 6-unit or 12-unit dose. And it was an environmental exposure chamber. And David Bernstein is one of the authors on this. I had a chance to chat with him about it, and he said one thing that was fairly unique is there was not increasing levels of exposure, but this was a steady state environmental chamber, which he thought, they thought was a representation of what we have in real life, so to speak. So that was something that was a bit unique. And so they did a challenge. The challenge was an inclusion period where they had to, determine whether or not people met criteria. Then there was an 8-week, 16-week, and 24-week evaluation. They scored it, the total nasal symptom score, at a maximum of 12. So there was four markers, and they could range anywhere from 0 to 3. They had a total ocular symptom score, saying 0 to 3 with a maximum of 6. And then they talked about monitoring IgE and IgG4 levels. Honestly, during the presentation, those levels were not, they weren't part of their discussion. So they monitored them, but wasn't presented. The inclusion data or criteria included was adults greater than 18 or older, perennial liquid rhinitis for at least a year, epicutaneous testing positive for dust mite, specific IgE positive for dust mite but greater than 0.7 AU, and a total nasal symptom score of at least 6 of 12. The exclusion criteria was an unstable FB1. If it was less than 70%, they were excluded. And if they had ever previously been on skip or slip. Now, in looking at this, I did my best to try to put this together. So they did a screening, and then there's your entry criteria: history, specific IgE, and skin prickness. I forgot to say next. I guess we're on that slide. They went to the environmental exposure chamber where they had a positive, again having at least a symptom score of 6 out of 12. Then they were randomized into 3 groups, 42 in the 12-unit group, 41 in the 6, 41 in the placebo. And then they were challenged. So they were challenged at 8 weeks, 16 weeks, and at 24 weeks. So the way it's on the bottom, this is the scoring system, the total nasal symptom score. You can see rhinorrhea, congestion, sneezing, itching. Total ocular symptom score is itchy eyes and watery eyes. And they also did one that was the total symptom score where they combined those two. So and the next slide looks at the outcome. Now these numbers are changed above placebo effect. So I didn't add in the placebo line because it wasn't in the abstract and I wanted to be accurate. This is the way it was presented in the abstract. When they presented it on the screen, they did include, but then the numbers were a bit different. But this is compared to placebo. So the 6-unit oral dissolvable tablet at 8 weeks, it was 10% versus 12-unit at 23. At 16 weeks, there was 18% improvement with the 6-unit, 28 at the 12. And at 12. And I think this is pretty much in keeping with what we've seen in other sublingual and the oral developed tablet data. Although actually I thought it was a little better. That I think when you see the 16-week scoring at 28%, that's really above placebo. That's been a number that I think has been more commonly published. So when this is taken for a longer period of time, 49% at 12 units was more than placebo was better than average. The total symptom score, the same scenario as you can see, except there was a pretty marked difference early on with the 12 unit over 6, so 34% improvement at 8 weeks, 32% on the 12 unit at 16 weeks. The 6 unit kind of caught up, so there may be a cumulative effect. So at 24 weeks, there was a 41% improvement in ocular symptoms compared to the 68% improvement in the 12 unit. There was a few patients that discontinued due to adverse events, 15% for placebo, and then for the house dust-mite oral dissolvable tablet, 7%. On the next slide, we'll list out the adverse events. And again, the adverse events is probably, again, in keeping with what we've seen in studies. In the 6 unit house dust-mite, 61% of patients had adverse events, were in the 12 unit, 76. The adverse events were throat itching, oral itching, mouth edema, lip edema, and tongue edema. And there was no serious adverse events. All the adverse event symptoms resolved within 1 to 2 weeks. So next slide. In conclusion, they found that they felt that this was a potentially high and clinically meaningful symptom reduction with the oral dissolvable tablet dust-mite. That was dose dependent with the 12 EU exhibited the best benefit risk ratio. And it would seem to be well tolerated, at least well tolerated in comparison to other sublingual and oral therapies in that it did not have systemic reaction, but you can anticipate there'll be some local effect. I asked about issues like perianal itching and rash, and they did not experience any of that. So that's any questions I can answer on that?
This product already marketed in Europe? I think the Germans have had sublingual for 6 years already. So there should be a worldwide experience.
There's certainly a lot of literature out of Europe. I don't know if this particular product is already marketed. It's certainly this is the phase 2A trial here. I don't know if this particular product is. I know that obviously they have a lot of stuff therapy available, so I don't know the answer to that.
Lisa, you're going to do some more on this exact topic.
Yeah.
Did they do any science and measure IgE or IgG4, or was this just all clinical?
Could you repeat that for me, Drew?
Was there any science that they measure IgG4
Or IgE?
or IgE? I think you said in the beginning they measured it, but you didn't see it.
Yeah, they did. They measured it, or that was one of their criteria as far as what they were going to monitor through the study. But if it came up, it was really not a focal point of a discussion, and I didn't see it. It wasn't in my notes, and I pulled the abstract that was available, and it was not in the abstract either. So I just don't know. I just don't know.
I have some notes on that. There was a separate symposium exclusively on this, number 2611, and Steve Durham was the first presenter, and so he sort of summarized a lot of literature, and clearly IgG4 and IgA2 both increase. So especially by giving it orally, you get an increase in subclass A as well as 4, same thing you would see in subcutaneous. I mean, there's a lot of discussion about this. Maybe Lisa will talk about it now. My impression up till this year's meeting was that subcutaneous was still a little bit better than sublingual, and I sort of came away from this meeting that they're almost equal. And I don't know, the Merck people in the room here, I think they were almost hoping that GRAS would be approved by the time of this meeting. Obviously, it's not yet, so there wasn't any promotion of the product, but it's not too far away.
And I think another point that came out, and Lisa may cover this, I'm sure she will, was in looking at sublingual versus the subcutaneous, although you may get a short period of time of tolerance where they stop therapy, and after a year or two have to restart it, where the subcutaneous does tend to provide a more long-term benefit after completion of the series. So that was also highlighted during some of the comparative talks. And then as far as quality, when you're looking at polysensitivity, I did not see a paper on multiple antigen sublingual, so I don't know where we are with that.
There has been work on both dust mite and grass together.
It's a statistical rule that when you have improvement with two things, one a little bit more than other, you have to have a lot of patients to be able to tell the difference. So comparing the two, you have a type 2 statistical error.
Well, we're going to steal Lisa's thunder here, but the other point that I think most American allergists have been wondering is, where do the Europeans find monosensitized patients, and we never have those patients, and how is this going to work? And the one thing that impressed me is that if you treat people, say, with just grass, they're actually symptomatically improved for their other seasons as well, because they don't get a priming effect from the one. So the idea we might be able to get away with one or two, like ragweed is pretty close to release as well, sort of takes away that concern that, we mix 10 things together and we desensitize them to all, may not really be necessary.
So kind of following up to Jeff's talk, I'm going to talk about allergen immunotherapy. This is going to be more of a big overview review. Thank you. So Linda Cox gave a couple of talks. One of them was a plenary session where she was discussing some of the data comparing subcutaneous and sublingual and some of the issues that are kind of facing immunotherapy as it stands today. And then she also gave us a really good talk in our fellow session, just kind of highlighting some of the novel strategies for immunotherapy, some things that are being studied, and where the future of immunotherapy may lie. I have no disclosures. So these are some of the modalities. Obviously, we've talked a lot about subcutaneous and sublingual. I'm going to just touch briefly on some of the more novel strategies that have been studied to highlight a study from each of those. And with regards to subcutaneous and sublingual, I'm just going to touch on those briefly, so this will not be in as much detail. So one of the things that's been highlighted in the session was discussing the safety summary of subcutaneous versus sublingual. Now, this is with regards to conventional subcutaneous. We're not talking about accelerated schedules. And we kind of touched on a lot of this already in our talks earlier today with regards to the sublingual, but comparing them safety-wise, obviously subcutaneous is notorious for having more systemic reactions. The numbers they highlighted in the session state about 0.2% of all injections are going to result in some kind of significant systemic reaction, whereas with sublingual, as we mentioned in the earlier talk, more mucosal symptoms, local symptoms are going to be more of what you see and not so much systemic reactions. Those are less common. Obviously, we know what some of the risk factors are for subcutaneous in terms of people you might want to avoid doing subcutaneous immunotherapy with, people who have uncontrolled asthma or have had prior systemic reactions. Risk factors for sublingual, people who might not be good candidates for sublingual, that's not as well established. And then I'll talk about the efficacy in just a minute, but some of the other things that we just mentioned and touched on, sublingual does seem to be somewhat efficacious for these single allergens, as you mentioned, for grass allergic folks and others, but when looking at multi-sensitized individuals, it's a little bit less clear how useful that's going to be. So this is one of those kinds of slides that just makes your eyes glaze over, but basically this slide was kind of looking at the efficacy of subcutaneous versus sublingual and a bunch of different individual studies that compared their efficacy. I think if you look at some of the individual studies, as you alluded to, some of them do seem to suggest that subcutaneous is a bit more effective, but overall the conclusion is that they're relatively similar in efficacy from the studies that have compared them so far. So the jury is still out in terms of if one is slightly better than the other. As you mentioned with regards to kind of the lasting effects, that's something that may be a little bit more beneficial with regards to subcutaneous versus sublingual, but still trying to
If you look at the numbers, like I mentioned earlier, the ones that have more people, you start getting the superiority, whereas the smaller studies, it's less clear.
Yeah, I agree. And then one of the other issues that was mentioned at the plenary session, which is kind of what the problems are that we have now with immunotherapy in terms of measuring outcomes, safety, adherence issues. With regards to outcomes, one of the problems is that there's no real gold standard for measuring immunotherapy outcome. Generally accepted measurements include things like looking at symptom score reduction, medication use reduction, and generally what's considered clinically relevant is anything that's 20% or more improved over the placebo. But there was mention about how there needs to be a more patient-centered assessment tool, something that kind of highlights, is this relevant to the patient? Is the patient finding that this therapy is as beneficial as what we're seeing with regards to symptom score reduction? Obviously, safety is something that we've discussed, sublingual being slightly less risky with regards to causing systemic reactions, but still something that's an issue with both. And then with regards to adherence, that was another thing that was touched on in detail, and that is, trials look like adherence is much better than what it is in real life, so other strategies and therapies that may improve adherence or have less issues with safety, these are things that are kind of potentially the future of immunotherapy, and I'm just going to touch on that briefly as well. So,
while you're on adherence, I sort of naively thought people would be very adherent to sublingual. You send them home, they just have to do it. It's actually terrible. Both of them are pretty terrible in the data, but it's like 20% of people adhere. I don't know how much easier it could make it for people. But anyway, I don't know if you're going into that in more detail.
Yeah, no, I don't really go into it in more detail, but I mean, it's a good point. Anything you have to remember to take on a fairly regular basis. Just like with pharmacotherapy, it's difficult for most people to do for some reason.
If you look at it, there was a compliance study done at the VA a long time ago, and obviously it was the VA, so you sort of wonder about the statistics a little bit. But they ask them to take a pill a certain number of times per day, or the outcome is they're going to die if they miss a pill. And in 30 days, 90% were able to maintain it for a month at once a day. Twice a day was 40%, 3 times a day was 23%, and 4 times a day was less than 10. And that's with a pill that you think you're going to die if you miss a dose. So our compliance numbers are just horrible.
I was supposed to put eye drops in for months after my cataract. I've forgotten now if I'm supposed to be doing it anymore.
So I'm just going to touch briefly on some of the different novel strategies that are being studied that may be more prevalent in the future, and talk about some of the benefits or potential things that would be beneficial with regards to these. So recombinant allergens is one thing that's been proposed as a potential new therapy. Recombinant allergens are basically purified allergens that have allergen-encoding DNA, and the idea here is that they're supposed to improve standardization and quality control. They still obviously have the same potential IgE-related side effects as the commercial allergens that are available, although they are also looking at making hypoallergenic recombinants. So this particular study from Jackie was looking at birch pollen allergic oats, and they compared commercial birch pollen to a natural purified birch pollen to a recombinant to placebo. It's a typo, but they were receiving 12 weekly injections followed by monthly injections over a 2-year time period. And they were just looking at those different groups compared to placebo. And what they found, this slide basically shows on the right, I guess it's on the right side of your screen, the symptom score and medication use score for each group. The top line there is the placebo in each of the graphs.
You gotta shake it.
Sorry. Backwards. Okay. So the top line here in each graph is the placebo group in both of these, and then the other 3 are down here, kind of overlapping in some groups. But basically what they were trying to highlight is that all 3 treatment groups had a significant reduction of about 50% with regards to both the symptom score and medication use during 2 consecutive pollen seasons. This is actually from the second pollen season. And they found that all of the treatment groups had a decent increase in specific IgG levels. They don't comment if that's IgG4 specifically, but they did find that there were even higher levels of specific IgG in the recombinant group, kind of trying to imply that perhaps the recombinant allergen would be even more efficacious in terms of inducing tolerance. Peptides peptide immunotherapy, another novel strategy. And peptide immunotherapy is basically a synthetic peptide that contains T cell epitopes. So you're trying to induce the T cell response, particularly Tregs, which potentially will blunt the allergic response. However, they lack T cell epitopes, meaning they're potentially more safe because they're not going to be cross-linking mast cells. And so this is a therapy that's potentially interesting for having less side effects. This is a study also from Jackie recently that looked at cat allergic folks. The peptide they were using was FILD1, and they used 2 different dosing regimens. One was giving 8 doses of a 3 nanomole concentration every 2 weeks, or 6 nanomoles every 4 weeks in 4 doses versus placebo. And then they were exposed to an environmental exposure chamber both at a baseline and at various points along the way. The graph I'm going to show you in a minute is 50 to 54 weeks after starting treatment. They kind of did a symptom score analysis at that point. And what they found was the change in the symptom score before and after treatment with the 2 different regimens over a 3-month period was relatively interesting. With regards to the 6 nanomole dose, they found at the 50 to 54 week mark, when they exposed people to the cat allergen at the exposure chamber 4 consecutive days in a row for a 3-hour time period, what you're seeing here is the difference from the baseline symptom score, and the group here in green is the group that was given the 6 nanomole dose versus the placebo group. So they did have quite a significant change in their symptom score from baseline at 50 to 54 weeks out after starting the treatment. And again, the treatment just lasted for 3 months. So what they were trying to show here is that there was pretty sustained lasting effects from the peptide immunotherapy. They did remark that the 6 nanomole dose was somewhat more efficacious than the every 2-week therapy. Epicutaneous obviously is another route or mode of immunotherapy. This is used both for allergen and food in different clinical trials at this point. This particular study from Jackie in 2012 was looking at grass allergic folks, and they were randomized to receive 1 of 3 different doses of allergen, low, intermediate, or high, or placebo, and they received this during 6 weeks. They got a different patch in the pollen season of 2008. They looked at them both within that pollen season and then in the follow-up season the following year when they weren't receiving any treatment. Efficacy was assessed 4 to 5 months later and during the fall pollen season, and they found that particularly in the high dose group there was a reduction of symptoms by 30% in the first year and 24% in the second year compared to the placebo group, which was significant as well. This slide is basically just showing side effects. So what they showed in the low, intermediate, and high dose group, the most common side effects, as you can see, is pruritus, and then all the other side effects were basically local. They didn't have any significant systemic reactions, so again, potentially a safer route for doing inhalant immunotherapy. This lower graph here is just showing how with each subsequent patch, the amount of local side effects seemed to decrease. Obviously, the higher dose had more local side effects, but you have a subsequent decrease in terms of the side effects reported with each dose. And then last one that I wanted to highlight was intralymphatic immunotherapy. So again, this is perhaps a little bit more invasive in terms of the way that it's administered, but you're going to be giving allergen directly to the inguinal lymph nodes. The potential benefit of this is that it's much shorter in terms of the duration of therapy and the amount of extract patients receiving. So this study was looking at comparing subcutaneous with 3 injections of the intralymphatic route. And they did either 54 injections of subcutaneous over 3 years or 3 injections to inguinal lymph nodes at 4-week intervals. And then patients were evaluated at different time points, 4 months, 1 year, and 3 years out by various different tests, including nasal propagation, etc. Basically, one other thing they highlighted was that compared to the skip patients, the ones who were getting intralymphatic were getting 1,000-fold less extract time. So much reduced in terms of dose, but what they found with regards to efficacy was that, I'll get to that in a minute, with regards to symptoms, they found that intralymphatic folks had a lot less in regards to mild, moderate, and severe symptoms compared to the subcutaneous group. And in terms of efficacy, what they're showing here is that the intralymphatic group at 4 months had a significant reduction in their symptom score. This is baseline, and the open white dot is 4 months later. When you look at the subcutaneous at 4 months out, obviously there's really not much difference with regards to the symptom score from baseline. This graph here is also looking at the maximum dose of allergen that was tolerated, and again at 4 months you see a difference between the intralymphatic group and the subcutaneous group in terms of the amount of allergen they're able to tolerate. So the potential benefit of this was that a much abbreviated course of therapy, and the impact in terms of what you're seeing with regards to symptom reduction was seen a lot quicker, a lot sooner compared to the subcutaneous group. So again, just kind of a brief highlight of some of the more novel strategies that are being studied and a little overview of issues with regards to comparing subcutaneous and slit with regards to safety and efficacy. But the take-home points that were kind of impressed upon us was that the sublingual, obviously we've talked about the efficacy and safety, this has been established, but it also potentially has adherence issues, as you mentioned. This is most likely to be the next new immunotherapy product that will be improved compared to some of these other strategies that I mentioned. They're relatively early in terms of the stage of study that's going on with regards to those. But there's some potential benefits that down the road we may see more of this. Recombinants, again from that one study with the birch pollen, they're implying they have greater efficacy in terms of the IgG response that was induced. Peptide immunotherapy seemed to show quite long-lasting effects 50 to 54 weeks after starting the treatment with the cat peptide. So that was particularly promising with that study. And then the intralymphatic and epicutaneous routes. Cutaneous is obviously a lot less invasive, intralymphatic a little bit more, but these are also potential routes for both inhalants and food allergens, although we're not discussing that in detail today. So again, just a bit of an overview highlighting some of those different strategies and kind of where we're at today with regards to immunotherapy. I know that was a lot of information.
How long before people come in wearing boxer shorts to get their info?
Yeah,
Honestly, where is that in the...
Honestly, I don't know what subset of patients would find that an attractive option, other than if you tell them, well, 3 injections are just as efficacious as 3 years of therapy.
Right, I mean,
you're going to see improvement a whole lot sooner. Some people would maybe go for that, but obviously there's issues with having trained staff to do that. It's a procedure of sorts, so.
I don't think anybody's followed up on that. I don't think it's ever going to come to fruition.
Was there much data on food immunotherapy? Because you sort of snuck that one in there on your last point.
Yeah. I mean, so that was something that was just mentioned in the take-home points that they were talking about. This session didn't really focus on food immunotherapy, but there were a lot of sessions that did discuss that in more detail. So this was more to just kind of look at inhalant immunotherapy and the different things that have been tried with regards to that so far.
To the point about recombinants, years ago, for those who are new in the field, people tried to just use AAAAI, is it from ragweed, the major allergen, and compare it with just crude ragweed. And the crude was better because, when you try and just do recombinants or single allergens, you miss the secondary allergens that people are allergic to, and at least up to my knowledge, currently, native allergens have always been more efficacious.
Well, the other thing, years ago, there was a big splash about using, bacterial motifs with like dust mite. For some reason, the CPG sort of repeats, and for some reason, that sort of simmered down at enough that it wasn't well tolerated. Or
people at Hopkins even formed a company to pursue that, and it seems to have disappeared.
The peptide cat thing has been around for over 20 years, so it's taken a long time.
Clearly, sublingual is going to be released in the U.S. The first product is going to be grass. I think the next is going to be house dust and birch and ragweed. I think all 4 of those will be in the U.S. market. We've got 2 other presenters to squeeze in here. 20 minutes. So, David.
Now we have hypoallergenic cat. How they do that too. Illinois deleted cat.
Has anybody tried to get credit online yet for the meeting?
For the meeting, I printed it out.
I can't get online to get it at the site. Has anybody tried?
It says you can't do it till the end of the month.
You found out that they can't do it till the end of
Hi, good morning. And I wanted to discuss or describe what I heard in one session about atopic dermatitis. This was a question from San Diego, so these are thunderbirds hiding from the rain in the zoo last week. again, I would start with definitions. So further analysis, we spend so much time and money on this project, so we must publish it somewhere. The first abstract that was presented was about a randomized multi-center study to evaluate the efficacy of intradermal flu shots in atopic dermatitis patients. Just a short background, so most vaccines are delivered either intramuscularly or subcutaneously. There are two common intradermal vaccines. One of them is the BCG vaccine and the other one is the rabies vaccine. In the recent years, there was renewed interest in intradermal vaccine, mostly because there are a lot of APCs in the intradermal tissue, and it was assumed that more APCs will be able to present the antigen better and then increase the efficacy of the vaccine. That was of special interest, especially since recently there was a shot in flu vaccine that was in the year 2004 and 2005, and if you can reduce the dose up to 1/5 of the complete dose, full dose, then you might actually prevent the shortage. There was also a question of cost, especially in poor countries, but I don't know if the cost is actually different between intradermal and the regular vaccine. And if you want to read more about the intradermal vaccine, these are two links that you can use. So first, people studied the efficacy of the intradermal vaccines. This is a summary of all major studies. First, they studied and compared full doses of both intradermal and intramuscular vaccines, basically no inferiority. And then they checked and compared reduced dose intradermal vaccine to the full dose intramuscular or subcutaneous vaccine. And again, maybe one study showed some inferiority, but generally no inferiority. And reduced dose in most of these studies is 20% of the intramuscular or subcutaneous full dose. And in 2011, the Fluzone intradermal was approved only for adult use. And again, the same contraindication, a patient with severe allergic reaction to eggs. And I don't know if we agree with that, shouldn't be given the vaccine, shouldn't use the vaccine. So the abstract basically raised the concern that the vaccine would not be that effective in atopic dermatitis patients. Atopic dermatitis patients assumed to have abnormal immune response. A subset of them are colonized with staph aureus, and the question is whether atopic dermatitis patients may have reduced immune response to the intradermal vaccine. The way they studied that was by checking hemagglutinin inhibition antibodies titers at baseline and 28 days post-vaccination. More than 200 patients with atopic dermatitis and 135 normal controls were studied. And the response was studied after a single dose of the flu vaccine. Analysis included subjects who were seroprotected to begin with. So the results, seroprotection and seroconversion rates for all three influenza strains, B, H1N1 and H3N2, were studied. There was no significant difference between atopic dermatitis patients and non-atopic patients. The rates were also similar for atopic dermatitis patients receiving the intradermal vaccine and the intramuscular vaccine. But with further analysis, based on staph aureus colonized patient or status, the atopic dermatitis patients which were colonized with staph aureus had diminished response to intradermal vaccines. And that was most impressive for the B strain, only 12% versus 47%, which is not very high as well. And the seroconversion rate was 21% versus 51%. Again, lower seroconversion rates for H1N1 and no difference for H3N2. And there was no difference between staph aureus colonized versus uncolonized patients following intramuscular Fluzone shot. So the problem was only with the intradermal vaccine. The conclusion is that among atopic dermatitis subjects, staph aureus colonization might suggest or imply risk factor or suggest that the intradermal vaccine will not be that effective, and therefore you might want to avoid that. Why? There are several options that were mentioned. First, staph aureus may induce Th2 response. They didn't show any evidence for that. The other option was that the other way around, that staph aureus induces IL-1 production, and that drives migration of DCs to the lymph nodes. So basically there are no DCs in the intradermal tissue. They all went to the lymph nodes, so they can present antigen. And the last option was that staph aureus colonization by itself reflects abnormal skin immunity, and inability to clear staph equals inability to mediate an immune response. So probably one should avoid intradermal flu zone in atopic dermatitis patients. The second study that was described, I think it was a very nice study. It's a very, I don't know if anyone heard about the group, the Health Nuts study team. This is an Australian group, and they seem to collect, to at least establish a very large database on patients. And they're asking the question, which infants with eczema are at greater risk to develop food allergy? Previous studies suggest that up to 80% of pediatric patients with severe eczema have evidence for food sensitization, either SPTs or food IgE. The risk of food allergy was rarely examined in the general population, so they just want to get out there and check what happens in the general population and try and characterize what are the risk factors for real food allergy. So the way that it was done, the way they describe it, the prevalence of food allergy to peanut, egg white, and sesame was measured by oral food challenge and was calculated for 12-month-old infants, etc., etc. What does it mean? I don't know, because I was just starting getting text messages with photos. So then I had to read about it, and they actually published several papers so far. The first one was this year, and I never heard about this journal, but I think it could be published in a different journal as well. So it's a large-scale population-based study, which was the first study. Was meant to assess the prevalence and risk factor for allergic diseases in early childhood. They recruited almost 5,300 one-year-old infants. They just went to immunization clinic and recruited everyone that was there. Patient completed a questionnaire about their history and family history, and all infants following that underwent skin prick test to egg, peanut, and sesame. If that was positive, then they underwent oral food challenge test. Skin prick testing was repeated prior to the challenge, and food-specific IgE levels to egg, peanuts, and sesame were also measured. They didn't check milk because that's what was approved by the IRB, and that's the only reason. They wanted to add more foods in the future. The first study found almost 10% that almost 10% of the babies had immediate IgE-mediated food allergy. That was defined as positive oral food challenge test, either hives, vomiting, angioedema, all within 2 hours of the dose of the challenge food. It was also defined that the IgE-mediated food allergy was to be positive in the context of IgE sensitization, or either SPT of above 2 millimeter or RAS of above 0.35. And I don't know if that is correct for all the foods that were tested. What was interesting to me is that almost all babies had one family member with some atopy, either asthma, atopic dermatitis, or allergic rhinitis, and 70% of the babies, the general population, had at least one family member with some atopy. When they tried to calculate the risk based on the number of family members with atopy, then they made a conclusion that you need more than one family member to be at significantly increased risk for food allergy. So if the general concept today suggests that one family member put you at high risk for food allergy, they suggest that you need probably more than one. The health study too, and that's the data which was presented in this session. Again, high population participation rate, almost 73%. Oral food challenge was offered to all, 85% agreed. Maybe they will have higher rates with SLIT as well, because they seem to agree to everything. Oral food challenge was performed on all participating infants beginning at 12 months of age and within 6 to 8 weeks of sensitization studies, and they challenged 4,400 babies. All infants were challenged, whether they were sensitized, whether they had eczema or not, and whether they had exposure to the food before that. Eczema was defined either was self-reported or history of prescribed topical steroid for any kind of rash, or eczema on physical examination when the babies were tested. Food allergy as before, positive IgE in the context of food-specific sensitization. So, not that surprising, 1 in 5 infants with eczema were allergic to peanuts, egg white, or sesame. That the prevalence was 20.9% versus 4.1% in non-eczematous babies. The risk increased to 1 in 250% for infants with early eczema onset who required prescribed topical corticosteroid treatment. More increased risk even among patients with eczema included maternal allergy, and if the father was of East Asian ethnicity. Also increased risk with male gender and preterm birth. So their conclusion was that infants with eczema across the clinical severity spectrum are at increased risk of IgE-mediated food allergy. Risk is greatest among infants with early onset prior to the age of 3 months and more severe eczema. Infants with eczema could be targeted for advice about introduction of food, maybe intervention to reduce the prevalence of food allergy, and I think that the US conclusion should be maybe there should be no recommendation for food introduction for infants without eczema or without strong family history with more than 2 family members with atopy. And I also invited everyone to Australia in September, so if you don't have anything else to do, it might be a good time to visit.
Allergy there was defined as a positive challenge or just positive
yes,
IgE?
positive challenge. Positive
So
challenge
not just
and
sensitization.
No, that's significant response within 2 hours of any of these. The last study in this session, you must mention something about whole genome sequencing, otherwise nothing will be completed. So another whole genome or kind of genome sequencing to find an association with some gene, between some genes and atopic dermatitis. This time wasn't whole genome sequencing, it was targeted SNP analysis or Hagin chip analysis of atopic dermatitis patient. They found almost 240,000 SNPs in over 850 patients. They made the analysis, genetic association, further analysis, logistic regression, and bottom line is that the most significant replicated association was single nucleotide variants in phosphodiesterase type 4. They couldn't provide any more details whether the variance was significant, whether it predicted some abnormal protein, was it a loss of function, gain of function. But I think it is interesting because we have a drug that targets phosphodiesterase 4 that was Flomilast. It is approved for COPD. It was approved in 2011. Basically, it's an anti-inflammatory drug. I first thought that because it inhibits cyclic AMP, it's also muscle relaxant, but it's mostly anti-inflammatory. And I don't know, I saw some studies that showed some benefit in asthma from 2006, and I don't know if that will also be approved for asthma in the future. But in any case, if you see patients with that, maybe you can check if they have atopic dermatitis and whether it helped atopic dermatitis or made it worse. There was another
David,
one.
I need to save a few minutes for art.
I'm just saying that I'm not going to say anything about it. That was a very interesting session. It was presented twice. I think Dr. Williams was also attending the other session. But basically, that was a very nice lecture about nanotechnology and how it can improve the effect of vaccines. Another thing that they suggested that nanoparticles can be a very common cause for granulomatous lung disease, and basically whenever you see a patient with granulomatous lung disease, treat them with rituximab, no matter what the reason is. And that's a review from Nature Review Immunology about it, summarized the whole thing, and maybe I present it in another session.
All right, well, hopefully you followed all of that.
Yeah.
Those are pretty amazing studies from us. Joe, you had to do so many challenges.
Would an IRB in this country ever approve that study?
All the challenges and
Yeah,
highly
challenging all these
kids.
babies
They were
for
approved
foods
by
that
the
they're
time the
allergic
babies
to.
were
I
10
mean,
years old.
This is an interesting study on the local allergic rhinitis. These are people who are negative RAST and negative skin tests, and they were trying to find a way to be able to identify these without having to do the local challenges. So they did the basophil histamine release test on these. These were the people who were working with it in Spain. 28 to summarize, these things are short. 28 out of 32 of those with allergic rhinitis were positive to it, 88% by the basophil histamine release to the allergen. Of the local allergic rhinitis, those who are skin test negative, RASC negative, about half of them had a response to the basophil histamine release to the allergen, and they had healthy controls. Those who had rhinitis, non-allergic, challenge negative, or actually 1 out of 10 with non-allergic rhinitis, 1 out of 14 in healthy controls. Oh, what this tells me as I was looking at this data on the local allergic rhinitis, it looks like at least part of them are real, which kind of makes it's kind of scary because how many of the people we have who are skin prick test negative are still allergic?
So the top group are people who are by conventional markers allergic. The second group are people who are skin test negative.
Yes.
And yet have
and RASC
negative
negative
rhinitis.
Did they see if they had nasally eosinophil in these patients?
No, I didn't check.
And they
didn't do that?
And they didn't lavage them for local IgE? Or, you know?
I forgot how they tested it.
Or exclude polyp patients.
On your first page, you said they did a nasal provocation test, so they challenged them to get some outcome.
Yeah, but in terms of lavaging them, I guess I didn't look into that specifics. That's a good question.
I think this is true. I think there are people who just made local IgE in the respiratory tract and we don't detect it in the skin.
Yeah, well, we talked about that with pollen patients because of the effect of staph, as this sort of acts as a super antigen and actually creates local IgE production.
But this is local IgE to the allergens out in the air.
Yeah, well, this is too.
This is for mites.
It's a polyclonal response, so you get just about anything.
Yeah. The second study I found was kind of interesting. Use of C1 esterase inhibitor concentrate for angioedema related to things like ACE inhibitors. ACE inhibitor related angioedema looks very much like hereditary angioedema. Doesn't respond to antihistamines, doesn't respond to epi. There's a smattering of case reports of individuals who seem to respond to hereditary angioedema therapy. This is the largest group I saw. 11 patients who were worsening on their either ACE inhibitor or the ARB. They were worsening despite corticosteroids and antihistamines. They used a fairly large dose, 20 units per kilogram. That is a very, very hefty dose of Berinert. And this is a non-controlled study, but it's the largest study I've seen where they had a number where they treated ACE inhibitors. Doing a controlled study on ACE inhibitors related angioedema with anti-HAE treatment is really difficult. Docs tried to do it and they couldn't get enough patients. Iconobond has done a few of those, and I haven't seen any controlled trials out of them. I knew I wouldn't have much time, so I kept it short.
Why I never understood why people who are on ARBs get in.
Yeah, I don't understand that either.
That shouldn't happen.
It's not as clean as you would think.
Anybody know?
No, I would say that they're safe.
So why is this necessary at all? Just take people off their ACE inhibitors and you just conservatively treat them. Why bother?
These are people who are worsening.
They're going to get intubated if you don't do something.
Yeah, these are people who are sick and who are worsening. These aren't stable individuals. And there is a literature on ARB angioedema. And those who have ACE inhibitor-related angioedema do have a little bit higher rate of reactions to ARBs. Why it is, I don't know. I had about 15 years ago, I had an HAE patient who worsened with ARB. It was... but he was a train wreck of an HAE.
Glenn, if you look at the incidence of angioedema with calcium channel blockers and beta blockers, it's 3%. and it's less than that with the ARBs. It's 10% or 5 to 10% with the ACE1s. So
Well, I'm not sure those are related events.
No, I know,
People
but when you're saying why does it happen with an ARB, I mean, I'm not sure that there is any necessary correlation there because it's the same with beta blockers and calcium channel blockers. So I'm not sure there is a mechanism there that's different.
Well, it makes you wonder if some of them just have type 3 angioedema. And it's true.
It's bringing it out. That's a very good point. When I looked at this topic about 10 years ago, the guy was quick to point out those who were on ACE inhibitors were a higher rate of reactions to ARBs, but that the studies he quoted were really small and few.
You're not supposed to call it type 3 anymore. It's,
Okay,
angioedema with
Dr.
normal C1
related.
And I make a big point of that.
So is there any more in the way of diagnostic studies for that now other than send them to you?
You know, I didn't hear anything at this meeting about that. It's becoming a progressively larger problem. I can't tell crazy people from people with that disease anymore.
And you have the urticaria group too. So.
There are two people working on kinin measurement. The guy in South Carolina, the big guy with on urticaria, Al Kaplan has an assay where he looked at those who have type 3 and type 1, 2 and compared to normals, and those who had hereditary angioedema were clearly set off, and those who are normal were clearly set off. The type 3s were all over the place. Diets is coming out with a kinin level assay, and I don't know where they're at with it, but hopefully that will help clarify it a little bit.
$8,000 a treatment.
Any other comments?
$10,000.
My only other comment as far as roflumilast for asthma is the problem is the effective dose had a profile with side effects like the awful one. Like 25% of people had like vomiting or nausea all the time. So I think that's why it's cited low dose for asthma. The side effect profile is terrible. TH17 asthma.
Can you measure basophil release commercially?
Yeah, of course. Yeah, IBT does a lot of that. I can send you. I don't know if you can do it for any. I'll see if I've got a spreadsheet that shows what they do it for some drugs.